bifurcation management. About 15-20% patients have some kind of a bifurcation. About 40 to 50 patients today are complex and interventions in our practice here. And that is why it is very important to have a good strategy and a good hardware to treat these patients. As I said that, out of all the bifurcations, at least 30 to 40% patients have challenging bifurcation lesions, and there we have to be very careful. First, of course, in protecting them, and then making a strategy as to whether we put 2 stents or say 1 stent plus, just a regulating balloon. For side branch protection, we generally have to have a wire, at least definitely, and also we choose a stent which would not jail these branches so often, and that is why in these kind of situations, those stents which particularly have that kind of structure, especially the open cell designs and the 6 crown designs, are much more helpful. The challenge is that, of course, the stent has to have that capability that the side branch can be expanded well. Number 2 is that the lesion itself and the fibrotic nature of the ostium of the side branch is also one deterrent. That's why we have to sometimes use atherectomy balloons or scoring balloons or cutting balloons for these lesions. It is not so common now, because now we know how to handle these situations. So we do good dilatation, good pre-dilatation, followed by good post-dilatation, and also a kissing stent balloon dilatation to have a complete coverage and also complete expansion of these stents. For optimal side branch expansion of the stent, the thing is, stent should have expansibility. The limits of expansion should also be checked for each stent, especially if you are treating the main vessel and then are also doing the kissing balloon dilatation. So it is always better to know the expansion limits of these stents. We have tried these kind of many devices which are dedicated for bifurcation, but definitely each of them have their own benefits or risks. The success is to be measured both with anatomical assessment like angiographic assessment, ultrasound, or also sometimes with FFR or physiological assessment. If you have to do a good expansion and good dilatation of the side branch or good stent expansion of the side branch, otherwise the chance of having a MACE or an event is much more than expected. Why not? Definitely. Of course, these kind of innovative designs sometimes are very helpful, and we should be open to these ideas, because we still not know which one is the best way to handle the side branches. I think the data on the acute in-hospital outcomes of MACE and stent thrombosis, acute vessel occlusion, all that will be very important to know. And then, of course, long-term data on angiographic analysis or even clinical outcomes may be important. Thank you very much.